I was a very unhealthy heart surgeon. I was morbidly obese. I was pre-diabetic. And I recognized that I was going to end up on my own operating table. Along the way, I came to recognize that what I had been taught about heart disease, the disease that I had dedicated my career to fighting, was really not the whole story.
Hi, Dr. Eric Westman here, and welcome back to the Adapt Your Life Academy podcast. It's my great pleasure to have Dr. Ovadia, or is it Ovadia?
Ovadia.
Ovadia, thank you. I've heard it both ways, so now that we have you to clear that up, that's fantastic. So it's my great pleasure to have you on. Thank you for taking the time. I would like you to imagine nobody knows anything about you. And not that that's possible, but imagine you're talking to my group of people who already kind of know about keto and have a lot of questions from doctors about cholesterol, all that stuff. So who are you and how did you get into the low carb or keto space, if you will?
Yeah, great question. So, Dr. Philip Ovadia, I've been a cardiac surgeon, a heart surgeon now for over 20 years. And for much of that time, I was a very unhealthy heart surgeon. I was morbidly obese. I was pre-diabetic. And I recognized that I was going to end up on my own operating table, so to speak. I was traveling down that same pathway that so many of my patients have followed. So many of your patients have followed. And I recognize that, the advice that I had been taught to give them, eat less, move more, eat a low-fat diet, follow the food pyramid, it wasn't working for me and it wasn't working for them. And thankfully, I got introduced to some different concepts. My journey really started with hearing Gary Taubes give a lecture at, ironically enough, a Society of Thoracic Surgeons meeting. So picture, a couple of thousands heart surgeons in a room. And Gary's the lecturer. And at that time, Gary had just written The Case Against Sugar. Of course, before that, he had written Good Calories, Bad Calories, and Why We Get Fat. And, hearing Gary talk about that the types of food that we eat are more important than the amount of food that we eat. And the influences there, and mentioning things like insulin and insulin resistance, which of course, I had probably heard superficially during medical school, but never really paid much attention to. And read Gary's books and cut out sugar, went on a low carb diet, and ultimately lost, 100 pounds, reversed my prediabetes. And along the way, I came to recognize that what I had been taught about heart disease, the disease that I had dedicated my career to fighting, was really not the whole story. And there was a lot more than just cholesterol, which is really, the primary focus of the healthcare system when it comes to heart disease. And so, that's led me down a little bit of a different pathway. I'm still an active heart surgeon.
Yeah, before we go down the new pathway, so you're trained to do bypass surgeries, heart bypass surgeries?
Correct. Yeah. So I do open heart bypass surgery, coronary artery bypass, the most common surgery I do.
Which is kind of an awesome thing. I just have to say, I'm thoroughly in awe of that, the whole process, and having seen it a few times. And anyway, you work hard, right? I mean, it's hard work and it's life and death, and you're working on these arteries that are clogged. But most people who have come to this, even seeing the heart that's damaged and all, kind of say, well, there's cholesterol in there on the artery, then it's cholesterol in the food. I mean, duh, is kind of the thing that people say, and look at you blankly as if, like, the sun doesn't go around the earth. How could it? The sun goes around the earth. Look, it's in front of our eyes. So let's step back. In the training you received, you really weren't trained as a preventive heart person. It's more reactive, right? So that you go in and you repair things after the fact. Am I getting that right?
Yeah, that's definitely the case. I see patients at the later stages of their heart disease journey. And by the time patients have come to me, they're advanced their heart disease has become advanced. Now, many of the patients never knew that. They literally show up at the hospital having chest pains, having a heart attack, and they might be on my operating room table, right away or within a couple of days. And for others, they have known that they've had heart disease, and they've been seeing their cardiologists and their family doctors who have been, trying to manage this disease with them. And yet it still has progressed to the point now that it's advanced and they're coming to me for, open heart surgery.
Yeah, but so this is downstream from the initial process getting started. So how would you know how to prevent it? I mean, you would be listening to what all the other cardiology or other preventive people would be saying. And what kind of woke you up, other than your own experience, but you didn't have heart disease yet. You didn't say, but how would you be able to sleuth out that there's something other than cholesterol? Because that's really the paradigm of today.
Yeah, and that's really been one of the most interesting things about this journey. It's not what I was expecting. It's not what I was planning, but the evidence, I guess you could say, revealed itself to me looking at insulin resistance and coming to understand, and we're of course going to dig into this, but coming to understand that the vast majority of what I do as a surgeon is preventable and should be prevented. I'll even go that further step to say, the way that I now view what I do as a heart surgeon is just about every patient that has ended up on my operating table has been failed by our healthcare system, because we really do have the evidence to show us that more than 90%, 95%, maybe it's even as high as 99% of patients that end up needing coronary artery bypass surgery, that could have been prevented with a proper focus on, we'll just say for now, the risk factors. And, I think it's a failure of our medical system that we don't do a good job in preventing this.
I totally agree. Before we get to the new way, though, let's focus on the old paradigm a bit. And my patients come in with PAs, nurse practitioners, doctors following guidelines that say a cholesterol is elevated, you need to be on a drug for this. I mean, they don't even know if the person has a history or is going to get atherosclerosis. They've kind of dumbed it down to a cholesterol number. How do we get into this situation? What's your perspective?
Yeah, I mean, my perspective, how we got there, and understand, I graduated medical school in 1998. I do not remember hearing one word when it came to heart disease besides cholesterol was the cause of heart disease. And the way that we should prevent heart disease is with the use of medications and low-fat diets. And honestly, the diets were an afterthought. If you look at the guidelines carefully, they're in there, but it's really, like you said, look at this number on the blood test, the cholesterol level, the LDL cholesterol level specifically. And if it's high, you treat them with medication to lower their cholesterol. And that's the way to prevent heart disease. And, that was well established, like I said, when I graduated medical school in 1998. And it really became well established, I guess you could say in the early 1990s is when statins kind of came to prominence. And, here we are 30 plus years later, and heart disease is still the number one killer in the United States and worldwide. And, that was one of the things that I guess I kind of woke up to. I mean, it was always right in front of me, but I never really thought about it or paid attention to it, that, if all these patients are on these medications, why aren't we making more of an impact when it comes to heart disease? And that's the sad reality. We can talk about how much effect these medications might have, but ultimately we have to acknowledge that they must not be having the effects that we expect them to have, because here we are 30, 40 years later, they're the most widely used medications, and heart disease remains far and away the number one killer.
Yeah, getting back to Gary Taubes, who you mentioned, his book, Good Calories, Bad Calories, is a must read if someone's still questioning how could the whole medical system be focused on something so insignificant? It's the first half of that book is just brilliant, and bringing all the science together in a way that I haven't seen anyone else do. It's been really helpful for me to understand how the old paradigm got built. Although, you hear every now and then the residual risk, or there's this acknowledgement that maybe there's something else. What about this insulin resistance metabolic syndrome? It's actually been there for a while too.
Oh yeah, again, well known. We can go back to the work of Gerald Reaven, and even and Joseph Kraft, in the 1970s, 1980s, and even before that, we have the data showing how important insulin resistance is in all of this, and yet we don't act upon it. And you mentioned residual risk, and this is a term that comes up a lot in cardiology world. And to unpack it a little bit for people, it's basically the concept of, okay, we've controlled the patient's cholesterol level, yet they still develop heart disease. Why is that? And, it's kind of this nebulous term, residual risk, and you'll talk about other risk factors. There are things like smoking and high blood pressure and controlling those. But again, when I think back through my medical school, my training, my career as a heart surgeon, I really struggle to remember if I ever heard the term insulin resistance before really reading Gary's books and hearing Gary talk. And then of course, a lot came after that. But, and yes, you could say, okay, well, I'm a heart surgeon. I was trained to be a heart surgeon. I wasn't really trained, as you said, to prevent heart disease later in the process there. But you still would think that this term would come up, just understanding the disease that we were treating. I certainly was educated about what heart disease is. And, we went through all of the basic science and all of the stuff that leads up to it. And like I said, I really would have to struggle to say that I ever heard the term insulin resistance during all of that time.
Or how about the term inflammation?
Yeah, inflammation would be brought up, but again, not really as an important, so that term residual risk implies that all of these other factors are less important than the main risk, which is the cholesterol, as it was told to us. And it turns out that when you look at the studies and you look at the statistics, it turns out that LDL cholesterol is the residual risk factor.
Right.
It's the minor risk factor.
Yeah.
Yeah, inflammation, insulin resistance are much greater magnitude risk factors when it comes to heart disease. Yet our approach in medicine is the other way around. And people ask why that is. And, the only reason I've been able to come up with why it is because we have pharmaceuticals that modify cholesterol levels. And we don't really have those, medications that modify insulin resistance in the same way.
And doctors really don't know lifestyle change, right? So we've trained a generation or two of doctors who just give prescriptions, right, for medicines. The CME, the continuing medical education, is done by companies that sell drugs. And yeah, so I have to agree that doctors have plenty to do. And actually, you were quite busy repairing diseased arteries. How did you have extra time to go out and learn on your own? I mean, this is quite hard to keep up with a field of cardiothoracic surgery. And how did you come up with that great slide that I saw at a recent presentation that you gave, Virchow talking about inflammation on the arteries, 150 years ago?
Yeah. 1858 lecture from him talking about how inflammation preceded, what at that time he called the fatty metamorphosis, but atheroma formation. And, I guess I became so passionate about it because of course, my own journey, but then, understanding, like I said, the fact that, the majority of the patients that end up on my operating table shouldn't need to be there. And, ultimately our role as physicians is to do what we can to best improve the health of our patients. And one of the things that I now understand is, no matter how good a surgeon I might be, no matter how good all the heart surgeons out there are, you're never as good after you've had heart surgery as you would have been if you didn't need the heart surgery in the first place. And so that's kind of become my passion and my calling. And I also recognize that being able to deal with the patient in this sort of holistic way. Yes, the patient that shows up needing that heart surgery, and I'm able to offer them that heart surgery that may extend their life or save their life. But now I can give them the added dimension of helping them to understand why they got here in the first place and what they can be doing so that they don't end up back on the operating table. The sad reality is that the majority of patients that have bypass surgery, have stents, they live longer because of these treatments, but they still die of heart disease. And again, that's something that I think we can change as well.
Well, thank you for making the change. There's something different between cardiologists and cardiothoracic surgeons. Well, the training's very different, right? The cardiologists are dealing with the problem earlier on, although many cardiologists aren't into preventions. I say most aren't. They're procedure oriented as well. There are preventive cardiologists, though, but it seems like even here at Duke, where I practice, the cardiothoracic surgeons they're open to this. I mean, they send me their patients who are too heavy to get a transplant. And so you can imagine my surprise when the first LVAD, the ventricular assisted device patients showed up in my office when I never had LVAD patients in the 1980s when I was in training. And so I was checking for a pulse and he's pulseless. And anyway, about LVADs, the heart has failed so much that there's a little pump put inside the chest to actually push the blood around. And so the cardiothoracic surgeons started sending me patients because, they're already so sick. And all I do is change the food. I don't even add new drugs to the mix. But the cardiologists have a different it's almost like they've gone to the church of LDL. And it's very hard to talk anything other than LDL when you're in the church of LDL. And, you don't go into the Catholic Church and say there's no God and expect to be welcome, right? So is that your experience too, that most cardiologists just have been seeped in this old paradigm? It's hard for them to see outside it.
Yeah, very much so. I think it may be changing a little bit. And I think it may be changing because the cardiologists are starting to recognize the futility of what they do and how it's not working. And similar to I just finished Sarah Hallberg's book, and of course I know you know her well and was mentioned in the book. And the frustration that she expressed at not seeing progress in the patients that she was taking care of at the beginning of her career. And I know many other internists and family physicians have expressed this as well. And, I think a lot of the cardiologists are starting to see that as well, because they're treating these patients with these medications, they're lowering their LDL cholesterol, and yet they're still developing heart disease. And it just seems to be that endless, there's a never ending supply of these patients, and we're not really making progress. We're losing the war against heart disease. And so I think even the cardiologists, not in large numbers, but I'm starting to see some pockets of hope, I guess I'll say. And they're coming to recognize that we need to do better for our patients.
Yeah, well, I guess I would generalize even within all of internal medicine, cardiology kind of rules the lipid world. And so most internists like me, I'm trained as a general internist, follow the cardiology, LDL. They're not into the triglyceride and HDL, the metabolic syndrome components in the blood. But boy, I try to teach that as much as I can to my patients, and then go to the statin decision aid tool that the Mayo Clinic has online to help people try to understand, if they do use medicines, that the amount of absolute risk reduction might be pretty small, actually. Do you now, stepping back, thinking about prevention, primary prevention or secondary prevention, is lifestyle, and what kind of lifestyle? And then is there a role for drugs? And how do you put things together? Well, I guess, how was your transformation and what do you do today? And then we'll talk about how you address things today.
Yeah, so again, I think at the center of it is insulin resistance. And so it starts with, first of all, let's figure out, is the patient insulin resistant or not? And again, we have the studies showing that when you're looking at heart disease patients, the answer is almost always yes. And studies going back to, again, the 1960s, 1970s, demonstrating that 95% of the patients that show up with heart disease, with a heart attack, are insulin resistant if you look for it in the right way, if you do the right tests for it. So to me, the first part of it is, not even necessarily saying, ignore the LDL. It's just that acknowledging that LDL isn't the whole story. And let's look at this other things. It would kind of be akin to that same cardiology patient walking in, and we know that they're a smoker, and we know that they have high LDL, and we just say, well, let's treat the LDL, but we're going to ignore the smoking part of it. Like, that's not something we would do. And insulin resistance, it turns out, is even a bigger risk factor than smoking for cardiovascular disease. And yet we ignore it. And so, the first thing I try and accomplish with patients and with my colleagues, if I'm, working on educating them, is let's acknowledge insulin resistance exists, and it is a major risk factor for heart disease. And so let's test for it. And then let's talk about how we can mitigate that risk factor.
Great. And how would you test for it? Let's say now this patient's, one of my patients is watching, or yours. What should the doctor do to figure this out?
Yeah, so I think the easy things that we can do are, measure a fasting insulin level, look at the triglyceride to HDL ratio. And sometimes that's all we're limited to for various reasons, insurance or whatever it is, but at least if we got that, we can start to get a sense of, are they insulin resistant? Now, ideally, I like to go beyond that. My probably preferred way of assessing insulin resistance today is what's called the LPIR score, the lipoprotein insulin resistance score. This is a score that's based on what we call the advanced lipid panel, or the NMR panel. So most people are familiar with, when they get their cholesterol measured, what we're looking at is the amount of cholesterol, or more correctly to say, cholesterol carrying particles in the bloodstream. And what the NMR, what the advanced panel starts to do is it looks at the quality of those cholesterol particles, specifically looking at the size of the particles. And we know that when it comes to LDL carrying cholesterol particles, the smaller the particles are, the more problematic they are. So again, one of the failings I think we have in this LDL-centric world is that we look at LDL too broadly, because it turns out that not all LDL particles in our bloodstream are the same. And part of the reason why I think the LDL management is so ineffective and inexact is because we're looking at LDL too broadly. And so we really should be zooming in on the quality of these cholesterol particles. That testing gets a little bit more complicated, but ultimately LPIR, the lipoprotein insulin resistance score, is the score that looks at the size of your cholesterol carrying particles and uses that to determine if you are insulin resistant or not.
Yeah, and that just comes on the standard printout if you do get an NMR lipoprofile test. Fasting, right, should be fasting if at all possible. But it's interesting, you went right to blood, where I would have said, well, it's the insulin resistance. I'd want to know the abdominal circumference and the blood pressure and blood sugar and then blood lipids, all of that constellation. Of course, I think you just assumed we wanted to directly talk about the blood, but in some cases, I don't even measure blood much if it doesn't change what I do. That's just kind of my general training in the VA, the Veterans Affairs hospital system. We were trained in the 80s and 90s, well, 90s really, that if you weren't going to change what you did, why measure it, right? So, I think, but having a baseline and seeing change is important for adherence. And so what kind of lifestyle changes do you recommend these days?
Yeah, and I'll say you're exactly right. Sometimes it's obvious that the patient is insulin resistant and you don't need that testing, and we have our 5 basic measures that you mentioned: the waist circumference, the blood pressure, the fasting blood glucose, your triglycerides, and your HDL, and that oftentimes is enough. You just have to pay attention to it and manage it. So, and for me, when we do determine that the patient is insulin resistant, I think the evidence at this point is overwhelmingly obvious that therapeutic carbohydrate restriction is the best way to deal with that. And, so that is my preferred approach. From a practical standpoint, we can get into all the different forms that can take. That isn't just one diet, but therapeutic carbohydrate restriction is really the overarching principle that can then help you to personalize that diet to the patient in front of you.
Yeah, well, and if anyone has a doubt that there's research, you can point up to the ketogenic book up on your shelf.
Exactly.
Pretty proud that came out last fall. And I show the ketogenic book published in 2023. And then side by side, I have the Osler textbook of medicine from 1923. And it's the same diet for diabetes. So, this going back to rediscover or have to actually, now I'm at that point where no, we really didn't have to come up with a ketogenic book. I mean, no one has shown that it's bad. There aren't any prospective clinical trials that show carb restriction is bad. But the onus, the power position was that they're bad. Everyone knew it. There was a taboo on high-fat diets. So it's, I kind of flipped around. Jeff Volek at a recent meeting, basically, when I asked, should I tell my patients to stop the carb-restricted diet? And he said, no, there's no evidence there's anything bad about a carb-restricted diet if you do it right, which, again, we didn't have to do all that research except for the fact that it was the wrong time, or it was a paradigm, a time where everyone thought eating fat was bad. The industry that pushes sugar has gotten a free pass. Even today, is there a study that shows eating sugar causes diabetes? Like randomize people to have sugar, no sugar. I don't think that exists, but it's so obvious that it comes out in observational studies. Well, anyway, that's kind of the argument that Gary Taubes taught me, that science will eventually find the truth unless you're not able to do the science that needs to be done. Like there's no funding to actually see if sugar is the culprit. Well, anyway, I got off on a tangent there.
Very much so. And when we look at it in the context of this, the low fat diet, and again, this, like you said, it's ironic and problematic that we're in this situation because, as you mentioned, you can go back to Osler, you can go back even further to Banting, in the late 1800s, talking about carbohydrate restriction. And then, but you really don't find, at least in the looking that I've done, no one's ever shown me, a low fat diet suggested that far back. And it really only became suggested in the 1970s, 1980s. And so now, and we've been running that experiment essentially now for 40, ish years. And the results are quite frankly disastrous, and they're all around us. And yet we still now are in a situation where we have to somehow prove that this, thing that we're talking about, carbohydrate restriction, is safe, while that is accepted as, safe, even though it clearly isn't, and has no evidence behind it. We have plenty of evidence showing the benefits of carbohydrate restrictive diets. I am yet to really see any evidence of benefits of low fat diets.
Yeah, the big study that was government funded didn't show a difference. The Women's Health Initiative, a randomized trial. Of course, the leader of the study said, well, they weren't following it well enough, Anyway, if you only believe in one thing, that's all you're going to see. Now, let's shift gears. Let's assume now we're in the clinic and someone doesn't know if they have, now I want to make sure this is a patient you might see. They don't know if they have heart disease or not. Their doctor has told them they need medication treatment for a high cholesterol. And how would you go about evaluating this patient other than, okay, you look for insulin resistance. Now, let's say there is insulin resistance. How would you counsel and then gauge measurements? I mean, now I'm getting into the idea of trying to look at the pipes ahead of time, looking at trying to prevent the disease. How are you putting this together?
Yeah, so this is another very important concept for people to understand, because again, our evaluation of heart disease is typically based on blood cholesterol levels. And the reality is that blood cholesterol levels tell you absolutely zero about whether or not you have heart disease.
Yeah.
Maybe there's some correlation, maybe there isn't. But I always say, if we want to know if you have heart disease, let's look if you have heart disease. And I think the best way for us to do that these days is with a coronary artery calcium scan. It's a fairly simple, non-invasive, relatively inexpensive test that can show you whether or not you have calcified plaque in the arteries of your heart. And yes, I understand that it's not a perfect test. It doesn't show us all the plaque. For that, you need a more advanced test called the CT angiogram. But, I think the CAC scan, the coronary artery calcium scan, is the best initial screening test that we have. And so I'm a strong advocate for this test. And as you said, it can also be used as a marker of progression of disease. We can get a CAC scan today. We can get a CAC scan a few years from now, and we can see, do you have disease and is it getting worse or not? And yet again, we don't utilize this test as we should in medicine. It is very underutilized. And instead, we kind of rely on this blood marker that, as we said, has nothing to actually do with whether or not you have heart disease.
I'd have to say the Duke in our area, and what's interesting is the doctors practice differently in different parts of the country. And in our area, they're just not used to ordering these coronary calcium scores. They're really not into prevention much, other than reading the tea leaves of cholesterol, and looking at LDL, not triglyceride HDL. So I'm afraid that's kind of just a different way to go about things. Do you ever, in our area, there's a company that will do the ultrasounds of your carotid and aorta for a small fee. I recommend that my patients get that just for getting more data on their body. Do you recommend those at all?
Yeah, those can be another, screening test, but again, they're indirect. We're not looking at where we're actually interested at.
Right.
And so I prefer the CAC scan, but in cases where maybe it's not available, the looking at the carotids or the aorta for evidence of atherosclerosis can be helpful as well. It's so interesting to me because you look at, all these other diseases that we really take more of a preventative or at least an early diagnostic approach. You look at something like cancer, and of course, breast cancer, women, know to get their mammograms. And the reason that we want to get the mammogram is because it's better to diagnose the breast cancer when it's a,
Really?
microscopic or very small tumor than when it becomes clinically apparent, which, can be in the very late stages of the disease. And yet heart disease, we don't take that approach. I view coronary artery calcium scans as the mammogram of the heart. We can see this disease process at its early stages. And yet, for some reason, we don't utilize the test. And it just really doesn't make sense to me. CAC scans are safe. They're low radiation. They're, very inexpensive on the grand scale of things. Usually you can get them done for around $100 or less. And they're non-invasive. And I just don't know why they're not utilized more.
Well, in our area, people have to pay out of pocket if it's not, so there's a false expectation that your doctor is going to know all the preventive things to do. So a lot of patients in my area don't want to pay anything out of pocket. And the monopoly or the ownership of different machines, of course, is part of it. You have radiologists, you have cardiologists, you have nuclear radiologists. Everyone kind of jockeys for position, but I really love your metaphor of the kind of mammogram of the heart for that. So now back to the patient, comes in, the coronary score is 0. What does that tell you?
Yeah, well, it's going to depend somewhat on the age of the patient. Understand that the younger that you are, the more likely it is that you have a 0 score, and the less predictive that that 0 score is. But ultimately, it tells us that you do not have any significant coronary plaque. And again, I always, I do understand the criticism that there could be non-calcified plaque there. And yes, there can be, but that's probably not going to be to a significant degree.
So the risk isn't 0, but it's very, very low that you'd have a heart attack in the next 10 years.
Exactly. If you're 50 years old, if you're a man 50 years old and you have a CAC score of 0, your risk of having a heart attack in the next 10 years is less than 1%. So it's pretty good. No test we have in medicine is perfect. And furthermore, we know, again, at least in people, 50s and 60s and beyond, with a CAC score of 0, there is no benefit to cholesterol lowering medications. This has been demonstrated in many studies. Now, you can say, okay, if it's a younger patient, maybe you can't make those same conclusions, and I think that's valid. But at least, in the young patient, what I tell the young patients, if you're 40, maybe even if you're 30, and you have particular risk concerns, go get that first CAC scan. Because yes, I understand the 0 score may not mean a whole lot, but the non-0 score in those patients is very meaningful. And it tells us we have a major problem because you've already started accumulating plaque at this young age, and makes it even more of an imperative to address things like insulin resistant. I would say I am yet to see a young patient with a positive CAC score more than 0 who is not insulin resistant. Maybe, heavy smokers, I guess, but honestly, I haven't seen it. If you're 30 and you have a non-0 CAC score, you're insulin resistant, and we need to address it pronto before it becomes a big problem.
Now, I have to keep reminding myself that the studies we're talking about don't treat insulin resistance for those patients, right? So they're getting the typical American approach, which is eat whatever you want and we'll give you pills. So my hope and hunch is that people who start changing their lifestyle won't have even that high a risk as time goes on, but that's a conjecture on my part. But now let's say that patient comes in and the coronary score is 100. And what's the range? I've seen different ranges, and not being an expert on it, I think it kind of depends on when the study's done and all that, but 100 is, pretty high.
Yeah, well, 100 is what I would consider, moderately elevated. So, these scores, I've seen them in the multiple thousands. I've seen 6,000, 7,000. I think the highest score I've ever seen is 9,000. So they go pretty high. 100 is usually a threshold where we start to think, okay, this patient may have significant disease. So, the patient that's now in front of you with their CAC score of 100, there's really 2 questions now that you need to ask. Number 1 is, do they have significant disease today that we might need to do an intervention on, a stent, bypass, something like that? Are they at imminent risk of, a heart attack? And if they're not, what are we going to do to stop this from getting worse? Because one of the other very interesting things about CAC scans, and again, that most doctors don't know, is that the progression over time of your CAC score is very predictive of your risk of heart disease. So you can have, to give a more dramatic example, let's say you walk in with a score of 1,000, and we do whatever testing and we determine you're not at imminent risk. If we rescan you a year or 2 years later and your score is still 1,000, that now puts you back into a low risk category, as opposed to if your score progresses. An average progression has been shown to be about 15 to 20% per year. So if we scan you again in 2 years and your score is now 1,200, 1,300, 1,400, you're you're at high risk. But if your score is still 1,000 because of whatever you've done, that now puts you back into a low risk category. So that's another way that the CAC scan becomes so powerful for us.
And explain to those who aren't used to this that the calcium is really a sign of healing, or so that if you have more calcium going up, it means you've had more disease and more healing going on. Is that correct?
Well, so this is a controversial topic, I'm going to say. So what do we know? We know that more calcium equals higher risk of disease. That's been shown pretty consistently. Now, there's been this inconvenient truth that has been uncovered as we do more CAC scans, and that's that patients who are on statins specifically, I haven't seen this data for the other cholesterol lowering medications, but patients that are on statins seem to have faster progression of coronary calcification. And so in an attempt to, I would say, explain this away, this theory has come up that that's a good thing, because what has happened in that patient is that the soft plaque that you're not seeing on the CAC scan has now turned to calcified plaque, and that means that the plaque is more stable, unlikely to break off, unlikely to cause a heart attack. The evidence to support that hypothesis, I don't think is really there, but that's what's been pushed forward.
So what do you want? The truth or a good story, right?
Yeah, exactly. And again, I go back to the fact that, I don't know, every study that I've looked at says higher coronary calcium, higher risk of disease. And so for us to think that, well, if you have high calcium because you're on a cholesterol lowering medication, it's okay. And if you have high calcium when you're not, it's problematic, just doesn't really make sense to me. So, and this is probably maybe getting a little deeper into the woods than we want. But again, this whole theory that, the atherosclerotic process starts with a soft plaque, what we call an aroma, and then it becomes a calcified plaque, and that's sort of stabilizing it, just I don't think has really been definitively proven.
Yeah. Well, so then what's the role of that CT angiogram? So the calcium score doesn't tell you directly about narrowing, but if you get a CT angiogram with a dye put in, and then the CT, you can actually have the artery itself shown and the amount of narrowing. How do you use that test?
Yeah, so as you said, the CT angiogram gives us more detail, but it is a more involved test. You have to give the patient dye. You're exposing them to a greater radiation dose. It's a more detailed imaging, but it gives us that additional information because it shows us both the calcified and the non-calcified plaque. And we can actually quantify now the degree of narrowing of that blood vessel. So, I use this test in a number of ways. The first would be that a patient with a very high CAC scan that isn't having symptoms, and we're concerned about whether or not they have enough plaque that, a blood vessel might be narrowed enough to require intervention. I think that's a good situation for a CT angiogram. Patients who have already had stents that maybe the CAC scan is not as applicable because that stented area is going to show up as calcified plaque, CT angiograms can be useful for. If we're trying to follow patients after they've had a stent, again, CT angiograms, rather than the more invasive cardiac catheterization test, I think these are becoming better and better options. The CT angiograms, the technology behind them has really advanced in the past, 5 to 10 years, and we're getting very high fidelity images. And we're even able to reduce the dose of radiation, which makes them more and more useful. I fully admit that I would love to be able to just do the CT angiogram as the screening test on everyone. But the reality is that, the radiation, the expense, the IV dye are all barriers to that. And that's why I still say the CAC scan is the better screening test.
But maybe that'll change over time. But then, I did my cardiology internal medicine training in the 90s, and there was always a role of the treadmill test, the functional test. And you would always look at an anatomic narrowing and not really know if it's flow limiting to the degree that you would need to intervene. So in fact, I was always a big proponent of the functional test. You know, if you have a drain in your house and it has a clog down there, but it's not limiting the flow, you don't go in and just preventively get rid of, you know, well, most people don't go in and fix the drain in their house until it has some sort of demonstrable blockage. So it's always important to talk about what someone's lifestyle is. I even had a marathon runner who couldn't go up the hill as well, and he found this really little lesion in one of the tiniest coronary tributaries. You have to balance the decision for the patient. What is the narrowing? What is the person's lifestyle? And I find that a lot of people are searching on the internet for the answer.
Yeah, no, and that's important to understand that we don't have the one test when it comes to this that gives us all the information we need. You mentioned stress testing, functional testing. We now have also what's called FFR testing, so fractional flow reserve or testing, because even when the patient is in the catheterization lab and the cardiologist, has put the dye directly in the artery and we're looking at it and we're visually assessing that, okay, this looks like a 70% blockage or an 80% blockage. We don't know, like you said,
clinical relevance
significant? Is that causing problems or not? So we now have what's called FFR testing, where we can actually measure the flow across that lesion and determine, is the flow being reduced significantly? And that's really become the gold standard to decide if that blockage, that lesion, needs an intervention or not. So these are all downstream testings that become possible, but it really, again, in my mind, starts with, let's look for the early stage of disease. And, as with everything in medicine, sometimes you don't, if the patient shows up to you with chest pains, obviously you're not going to start with a coronary artery calcium scan, so this is all context dependent.
You have chest pain in Durham, North Carolina, you're going to end up on the Duke cath lab.
Yeah, most likely, although sometimes in the ER now, they're doing CT angiograms in patients that they think it might not be, if they're thinking it might be chest pain for another reason, the CT angiogram can be a good test in that situation so that you don't have to go to the cath lab. And you see that becoming increasingly common.
Interesting. Yeah. And what the practice patterns are will depend on the relative influence of the different subspecialty, right? I mean, probably within a certain hospital, if the powers that be, they have more radiology emphasis, they may go toward the scans rather than if the cardiologists rule, then they'd go more toward the cath lab. Yeah, and of course, these behind the scenes things aren't publicly discussed, right? But I have enough people who've lived all over the country, they kind of figure out that things are done in different ways. Well, gosh, this is, I could go on and on and on. Any tips on how to talk to doctor, even cardiologists, about their heart disease or risk? Any pearls that you found useful?
Yeah, and I think this is probably, the common scenario that comes up. You and I have run into many times now where, you've started the patient on the therapeutic carbohydrate restriction. They're getting great results. They're losing weight. They're feeling great. Their insulin resistance has improved. Maybe you've gotten them off a bunch of medications, and then they go to the doctor and maybe their LDL cholesterol has gone up. And because of that, they're discouraged from doing this. And, in that situation, I think the discussion has to turn towards, what is the quality of the LDL cholesterol? This is where looking at the advanced panel and the particle sizes, and really maybe even without that, stepping back and saying, when you really look at the LDL studies that have been done in insulin sensitive patients, we've never demonstrated that same risk associated with LDL. So when you take the insulin resistance out of the picture, it's not clear that LDL in and of itself is problematic. And of course, there's a lot more science being done around this to answer this question, which has come up. but it really shouldn't be a barrier. Because in the end, I say, if you've reversed insulin resistance, if you've reversed your diabetes, if you've gotten off blood pressure medications, even if we think there may be some increased risk with that elevated LDL, the net benefit is still clearly in favor of, what you've done.
Okay, so
that's how I instruct patients to kind of think about this and talk to their other clinicians about it.
well, I like that because it's staying within their frame of reference of worry about cholesterol rather than just saying, don't worry about it. The triglyceride HDL looks great. That most doctors don't understand that even today, sadly. No, I loved your book, How to Stay Off My Operating Table. Is that right?
Stay off my operating table. Yeah.
It's a myth-busting book, basically, right? Tell me about the book a little bit.
Yeah, it really gives patients the blueprint, and it goes into all of these myths. The first section of the book is really focused on the myths when it comes to heart disease. And then it gives people the roadmap as to how to avoid heart disease. And it talks a lot about insulin resistance, metabolic health, what it is, how to improve it, and really how to feel your best every day.
Fantastic. Where can people find you? A website? Where should people look?
Yeah, so I'm at iFix Hearts everywhere. So social media, all the places, iFix Hearts. And then you can go to ifixhearts.com and see all the ways that me and my team are working with patients. My preventative practice is telemedicine based. I see people all over the US, and we have coaching programs and all of the various ways that we're looking to bring metabolic health to the forefront.
And do you like people with heart disease or all comers or?
Yeah, so I would say because of my background, I've attracted mostly people that either have heart disease or have a concern around heart disease. But we really, it all comes back to metabolic health. So the earlier people start paying attention to it, the better in my mind. And I'd rather see you before you have the heart disease than after. But either way, we're here to help.
Well, again, thank you. And I agree. And I hope what people who are watching understand the training that you've gone through to open chests and fix hearts. That's really such an awesome thing. Thank you for that. And now reminding yourself that you could prevent many more diseases, the disease in many more people than you could fix, because it's such hard work to fix things. So, but thanks for what you do day to day. Appreciate that.
Thank you, Eric.
Hope to talk to you soon. If you enjoyed this video, be sure to like, subscribe, and hit the notification bell, and check out adaptyourlifeacademy.com.